Welcome, everyone. So pleased to have you join us today. I am Jana Patterson. I'm the Senior Vice President for Global Child Health and Life Support at the American Academy of Pediatrics. As COVID changes from an acute crisis to an undulating pandemic, there are so many new challenges facing healthcare workers who work in the global health ecosystem. This webinar series, sponsored by the Section on Global Health, was developed in response to the unique issues facing global healthcare workers in the time of COVID. And while there are a multitude of webinars out there that address how to manage clinical care related to COVID, this series is a space to discuss the effects that COVID has on our own lives, on our partnerships, and on our global health communities. We look forward to sharing these perspectives from around the globe with you. Please note that the opinions shared today represent the speaker's own personal experience in their countries and do not necessarily represent official AAP policy. We're privileged to hear renowned experts share their best practices from the field and their stories of how COVID has impacted our global health communities and partners. All speakers have declared they have no conflicts of interest to disclose. I hope that you will offer the questions that you have in the Q&A box, not in the chat box, please, so that we don't miss them, but in the Q&A box. And as you ask your questions, you'll also note that we have another webinar coming up on the 25th, and you'll see that save the date slide again at the end. Today's webinar specifically will focus on how national professional associations have responded to disruptions in maternal and neonatal care during the time of COVID, with particular attention to guideline development processes to maintain MNCH services during COVID. You may have all seen the online publication in The Lancet as recently as the 10th, 2 days ago, that looked at over 20,000 births in Nepal and showed that institutional births or delivery in a facility was down by 50% during this pandemic, with an increase in stillbirth rate from 14 to 21 and an institutional neonatal mortality rate increasing from 13 to 40 per thousand. These really are quite dramatic shifts, and I think we're all anxious to protect all of the gains that we've made over the last decade in maternal and newborn health. So I turn it over to our speakers to tell us how they're implementing in their countries. Our first speaker is Aman Pulungan, who is the president of the Indonesian Pediatrics Society. Oh, I'm sorry. It looks like our first speaker is Professor Muhammad Shaidullah, who is the chair of neonatology at BSMMU in Dhaka and chair for the National Technical Working Committee on Newborn Health and the National Technical Advisory Committee of COVID-19. Welcome, Professor Shaidullah.
Sorry, you're on mute.
Sorry. Again, thanks, Jenna, and everyone attending this particular very interesting webinar. I'd like to extend my greetings, particularly to good evening to the East and good morning to the West, and like to thank American Academy of Pediatrics for arranging such a important events. Now, we all know this extraordinary pandemic, that is COVID crisis, which has affected the whole globe, and Bangladesh is not an exception. So I will share with you about the way that we have adopted the global maternal, newborn, and child health guidelines in COVID-19 pandemic in Bangladesh. Next, please. The first case that was detected in Bangladesh was 8th of March, and the first date was reported on 18th of March this year. So far, we have tested around 1.3 million people, and of them, it is 266,000. Actually, that's today's old figure. It is here. 1,000 people have been confirmed to be COVID positive. And we have deaths around 3,438 which is 1.32% death among the COVID positive cases. And the positivity rate is around 20%. So that's quite high compared to many parts of the world. Next, please. Now, as this COVID pandemic was affecting almost all maternal, newborn, and child health and other health services in Bangladesh, we had to actually prepare ourselves and had some response activities in Bangladesh. And as such, actually, we made a Bangladesh preparedness and response plan COVID-19, then National Technical Advisory Committee for COVID-19, where I am the chair now, and a COVID-19 dashboard, which is very important, that has been developed in District Health Information System 2, and we have national MNCH guideline in context of COVID-19. Next, please. Now, I will share with you how these maternal, newborn, and child health services have been affected. And if you look at the figure, I mean, I will have a comparison between the month of January, February, and March, and April, May, and June. And the worst month was actually April, where kind of lockdown in the name of general holiday, it was there. And actually the antenatal care visit number 1, it was reduced by 52% in the month of April. Then normal vaginal delivery in the facility has gone down by 41%. C-section was reduced by about 55%. Kangaroo mother care 77%. Newborn admitted in the NICU 46%. And also under 5 children received service in the IMCI corner was reduced by about 68% in the month of April, and which is not picking up, but I can share that in the month of July, we are having some good picture. Next, please. Now, why this reduction, or why we had some problem? Actually, based on 3 factors. One is access to health service that was hampered. One is fear to visit the health facilities in COVID situation, and financial barrier for care seeking of essential MNCH service. But I'll just share something about the access to health service hampered. How the facilities were overwhelmed with COVID cases. Readiness of the facilities to continue essential service was a problem. And particularly the human resources were deployed in COVID dedicated hospitals. So these are the main problems that we actually had. Next, please. Now, what we had to do, we had to actually restore our essential MNCH services. For that, what we did, we had the commitment and ownership of the government. And what we did, we set priority to ensure MNCH services essential. Formation of an interdepartmental committees, engaging the professional bodies for MNCH guidance, coordination, integration among the stakeholders, strategic guidance, and development and dissemination of IC materials. Next, please. So when we did this development of the MNCH guideline, we had group consultation for development of national guidelines, 3rd of May, and this was finally adopted on 18th May 2020. Next, please. These were the stakeholders. The government was in the driving seat. There were the development partners and the professional bodies. Next, please. What we did actually, we reviewed the existing global guidelines, and based on that, we had consultation with key stakeholders on reviewing existing global guidelines. We tried to resolve the competing school of thoughts and priorities in country context, because that's quite challenging. And after that, next please. The way we actually reviewed this global guidelines, I'm not going into detail of that. Next, please. So finally, we adapted, we finalized and approved. So that ensured the adaptability by considering multiple tiers of health infrastructure in Bangladesh. Then series of meetings undertaken for building broader consensus. And finally, national guidelines finalized and sent for approval, and which was approved on 18th of May and being uploaded in the Ministry of Health and Family Welfare website. Next, please. But we faced quite a good number of challenges. One of that, different school of thoughts in global guidelines, because This American Academy of Pediatrics and the WHO guideline had some difference in newborn care, maternal, and other things. So there was difference in opinion for continuation of essential service, like particularly whether we should be doing rooming in of newborn with mother, whether we should be continuing breastfeeding for babies of COVID-positive mothers, kangaroo mother care, number of antenatal checkup. Those were the issues. And finally, service delivery structure in lower healthcare facilities. Next. Next, please. So what we decided that we have actually 4 antenatal care visits in our national program. We continue to do that. We said that yes, breastfeeding should be continued soon after birth, within 1 hour. We said kangaroo mother care or skin-to-skin care both should be continued. And we said we should not do the bathing soon after birth. Still, the national guideline is delay bathing up to 72 hours when we are following that. Next, please. So these are the initiatives that were taken. One is the implementation of national MNCH guideline, establishing trials and isolated service area. This was a problem at the beginning because in many hospitals they were not admitting patients. Strengthening telemedicine consultation and appointment system, online platform for supervision, monitoring, and capacity building. And there are a few other things like particularly recruitment to fill up the HR gaps. Doctors and nurses have been recruited, and mass media communication is very much well placed in our electronic and print media. Next, please. And that are the things that we have done in order to combat the challenges of COVID-19, in order to keep going our maternal, newborn, and child health. And I hope that we are overcoming that and we see some good pictures in the month of July. Thank you very much for giving me the time.
Thank you so much, Professor Shahidullah. We'll save questions until all panelists have spoken. Next, it is my pleasure to introduce Dr. Christine Karanja-Chege, who is a lecturer at Kenyatta University and a pediatric and infectious diseases specialist, also a member of the Kenya Pediatric Association. Dr. Karanja-Chege, over to you.
Thank you, Jenna. It is my pleasure to present the Kenyan perspective on the challenges that have been facing maternal and child health services during the COVID-19 pandemic. Next, please. So that is just an outline of what we are going to go through. It's a very short presentation, so I will not go through that. Let's go on. Next. So a few words on the state of the epidemic up to the end of July. So our cumulative cases are inching close to 30,000, and deaths have mainly been in the elderly and those with comorbidities like diabetes. We've had about just over 300 recorded deaths up to the end of July, start of August. We noted an exponential rise of COVID cases end of May after the lockdowns were eased and the testing was ramped up. And 88, close to 90% of our cases have been asymptomatic. And that may be explained by our generally young demographic. Most of our population is below 50 years. So in the pediatric cases, we've had now, as of today, about 1,500 confirmed cases cumulatively. And so far, we've only had 10 deaths from COVID in the pediatric population, and those have been children who've been severely ill with oncological conditions. Next, please. And that is just to show us the age-sex distribution of the COVID-19 cases in Kenya. You will note that most cases are in the 30 to 39 age group and very few in the pediatric population. Next, please. And this slide shows us our integrated maternal, newborn, and child health packages, which has been adapted from what is recommended by the WHO. Next, please. And that is the booklet that we use. It's an integrated book that combines mother and child health. So it starts from pregnancy and all the way until completion of vaccination. Next, please. So this is from the WHO, the report that shows how countries have had their services disrupted during the COVID-19. I've put arrows to show areas of key relevance. Note that in routine immunization, there has been the most disruption, close to just mid 75% disruption. And the next arrow at the bottom shows the facility-based births. Not so much of a disruption there, which is a good thing. Next slide, please. Next slide. So at the start of the pandemic, we reported our first case in mid-March, as most countries, and we went right on to making guidelines. And one of the first guidelines that was made with the help of the Save the Children and in association with the Kenya Pediatric Association and the Kenya Pediatric Research Arm, we made the COVID-19 guidelines for the care of children. Next slide. And these were the key areas that we looked at. You will note that we did not look at case management because that was integrated into one guideline that had case management, interim case management guidelines, because those were to be updated. So this little booklet that I have shown us covered issues of management of children with concerning logistics. So routine immunization services, routine pediatric outpatient care, newborn units, kangaroo mother care, and how are children to be isolated in the facilities. Next slide, please. So with regards to immunization, one key recommendation was that we were to ensure that routine immunization services were not to be interrupted. So as much as possible, we were to encourage the caregivers to continue taking their children for vaccination and also to make the facilities conducive for babies to feel, infants and caregivers to be safe. So enough spacing and to be in a separate place from the routine care of children. Next, please. So another thing that we did was we harnessed the power of community health strategy. In our country, our tier 1 of care is community level services because these have the ability to reach the grassroots. So we wanted to mobilize community health workers so as to continue encouraging people to seek healthcare services and specifically immunization and maternal and child health services. The other thing that we made provision for was catch-up of immunization activities after or towards the end of the COVID-19 outbreak. In fact, these have been planned for the end of this year, although I doubt that we'll be at the end of the COVID-19 outbreak, but we are going to have catch-up immunization services. Next, please. The other guideline was that one for community health workers. Next, please. And note point 4, the community health workers were to provide information regarding the services that were ongoing, specifically routine immunization and antenatal clinic. So they were to be equipped with the strategies and training to enable them to do that. Next, please. So the third guideline of relevance is the reproductive and maternal and neonatal health services. So that was made and it incorporated how this care was to continue in the COVID-19 era. So next, please. So that's the outline. Next, please. Next, please. But what is the situation on the ground? We had a few challenges with people initially panicking, and there was a record low care seeking. So what happened is that outreaches had to be conducted so that people were not to miss out on the immunization services. Next, please. So that is just to show how such outreaches were ongoing. Next, please. And the reasons for the low attendance were cited as below. Some were patient-related. For example, some feared contracting COVID. Others feared testing and being sent to quarantine because initially everybody had to be isolated. And then there was inadequate PPE. So healthcare workers were turning some patients away. Next, please. Next, please. So just to wrap up, is to tell us that we have seen decreased outpatient service use, and we have also recorded decreased cases of pneumonia and diarrhea. It was reported that there were increased neonatal deaths, but the situation on the ground was not that. There possibly was improper reporting to account for the increased deaths. Next, please. That's just to show the low OPD compared to the previous 2 years. Next, please. And I've already spoken about the decreased diarrhea. Next. And as well, decreased pneumonia as compared to the previous 2 years. Next, please. And the inpatient admissions were also reduced. Next, please. And next, please. So as I conclude, I just want to show us that when immunization services decline, please advance to the next slide, then there follows the cases of vaccine preventable diseases as followed the 2017 outbreak after the health workers strike in Kenya of measles. So next, please, as I conclude, just go on next. Yeah, so the way forward, next slide, will be to just harness all the services, all the healthcare services, so that we can continue to encourage people to seek healthcare, to seek immunization, and we continue with strengthening our healthcare systems, because we have seen that when we have good sanitation, it is actually possible to reduce the illnesses such as pneumonia and diarrhea. And that is it from my end. Thank you very much. Over to you, Jenna.
Thank you so much. Next, I'd like to welcome Professor Aman Pulangan, who is the president of the Indonesian Pediatrics Society, as well as the current president of the Asia Pacific Pediatric Association, and on the executive committee of the International Pediatric Association. He's a senior consultant in pediatric endocrinology at the University of Indonesia. Welcome, Dr. Pulangan. You're on mute, sir.
Okay, how is it? Okay?
Excellent, thank you.
Okay, so sorry, it's a technical issue, okay. And also thank you, Jana, and also American Pediatrics to invite us to share what's our experience in Indonesia to the COVID-19. So I can tell to everyone that, you know, we have the first cases the 2nd of March, officially. So, and after that, it's an increasing, and right now, probably the mortality in the children, maybe we are the highest right now in Asia Pacific. I don't know if compared to America right now. Next, please. Okay. If our next, well, my talk today about, you know, the COVID-19 in Indonesia, and also COVID-19 in children, and how about our Indonesian pediatric recommendation, and also we have a telehealth, but we don't have time, of course, to share here. But we have right now also telemedicine also from our society. Next, please. Next, please. So Indonesia, we have 17,000 islands. So the size from east to west is the size of United States, and we have 34 provinces. So quite difficult to control everything. So there is inequality. If we can see about the data here, in some of the islands, let's say like in Papua, but in Java, all the area is almost infected. But in Borneo, Kalimantan, and Sulawesi and other islands, probably it's a small thing. But the thing is, because the migration of the people of Indonesia is so dynamic, sometimes, we cannot stop the COVID-19 transmission. So the confirmed cases right now, almost 130,000 cases, not because we don't have a lot of cases, but we don't have a lot of testing. And we don't do any tracing, we don't do any good tracing. And the mortality right now, mostly every week between 4 to 5%, 3 to 5%, and right now about 4.5%. Next, please. Next, please. Okay, this is, can you go up? Okay, this is the maps of mortality. And this is the green one, mostly from Java, and the yellow one from Sumatra, and also from Kalimantan. And there are not really much from Papua and also Sulawesi. Next, please. Next, please. And neonatal deaths, our infant mortality, that's still 2 digits. So right now, most of our mortality is from below 1 year old and also below 1 month old. Next, please. Next, please. Then there is a problem inequality about testing. You should go down again. Go down again. Okay. Go up, go up, go up. Okay. I think you should go up. Okay. This is okay. The most of the cases, the mortality is below 5 years, and then below 1 year old, and also below 1 month old. So we have confirmed cases from our society, 59 children, but the data from the Minister of Health, they have more cases, like probably 70 to 80 cases there right now. Next. Next. And we have to make the harmonization between the global guidelines to local context. This is the a picture from our hospital here. There is a rooming in also. Next, please. Next. Then the problem right now is high number of births. This is our most problem, because every single year we have 5 million newborns. So if the pandemic starts from March until August right now, I think it's around almost more than 2,000 baby born, and some of them are infected. Even the mother is infected, then after that we don't have enough testing. So this is the problem. And how to prevent double death of the mothers and baby during pandemic, and maternal and family knowledge on MNCH service during pandemic, including infection control, social context, extended family and tradition, belief, guidelines, social implementation, MNCH services, guidelines during pandemic in primary health care. So far during pandemic, we have released about 4 guidelines, and also the guidelines from the government, also from our society. The thing is, we have a lot of guidelines, but implementation of the guidelines, this has become a problem. And no one control how to implement guidelines. And in some province, there are good control of the guidelines, but in some province, there is no control of the guidelines. So MNCH service guidelines during pandemic, inadequate facility of safe MNCH service during COVID-19, screening test available, and PPE availability. So screening test availability is a problem too. And high rate of COVID-19 hospitalization in referral hospital disrupt MNCH referral. And most of the cases, they come to our hospital about 24 hours, 36 hours, or 48 hours. So there is the late cases. Most of the cases, the mortality cases is late come to the hospital. Next. Next. This is some of the guidelines from the government revision. There are 5 revision already, and we are part of them all for the pediatric guideline from here. Next, please. Next, please. Next. So far, we released 4 guidelines already. This is including 4 guidelines in school, guidelines in breastfeeding, guidelines in boarding school, and also guidelines in the online education from distance learning. We also make a guideline for this. Next, please. Maternal, newborn, and child health services. This is the guidelines. We have a collaboration with the OBGYN and also from other society like internal medicine. And then we give the guideline to the Minister of Health. Next, please. Next, please. Next. So what is our role in advocacy? From 17th of March, we have a regular meeting on the branch of the IPS every single week, and also collecting data, suspect, confirm that shortage of PPE, infection, control in the healthcare worker, problem in each branch, and also we release clinical guidelines, management including newborn, breastfeeding guidelines, immunization also. We give the guideline for the government, release recommendation education for parents and family, and triage, PPE and infection control, distribution of PPE, and also starting advocacy, Minister of Health, Minister of Education, and also House of Parliament, and also Indonesian Child Protection Committee, Indonesian Muslim Council, and joint collaboration also with other society. Next, please. Next. And also for explanation, some of the media also from Australia, from Arab, and also local news, they invite us also to explain what's happening about children in Indonesia. Next, please. Next, please. And this week, during the World Breastfeeding Week, we make a lot of webinars in all of the branch. And this morning, we make a webinar. I myself came to the palace of the Vice President. We make a webinar with Minister of Health, Minister of Women and Children, and also the head of the family planning as the Vice President, and also the lady of the Vice President. We just have it, and also related to breastfeeding, and also about stunting, malnutrition, and also about COVID. Next, please. Next, please. Okay, this is our presentation because it's only 8 minutes, and what we can share, we're still doing really hard. Our most problem is inequality in testing, not enough testing, not good tracing, and also we have to to make advocacy to everybody because they want to start opening school. And in 3 or 4 provinces, they start opening school right now. And we just heard there are 6 new clusters already in 3 provinces. And then they close the school. So this is quite difficult because we recommend the school should start actually in January in 2021. Thank you, Hannah. Yeah, ready for discussion later on.
Thank you so much. Next, it's my pleasure to introduce Professor Yusuf Traore, who is president of the Mali Gynecology and Obstetrics Society, as well as vice president of the African Society of Gynecology and Obstetrics. Over to you, Professor.
Good afternoon, good morning for everybody. Before I start, I'm very happy to be with you. And I want to greet everybody for all the person who has permitted us to present our experience about management of services during COVID-19 context. I want also to thank USAID department in Bamako, especially Mr. Frote, and all the members of our society. And slide, please. Yeah, here is our plan. We will first speak about the context of the COVID-19 pandemic in Mali. And secondly, the impact of the COVID-19 on maternal and neonatal care. And we'll finish to present how our society has responded to in this context. Please, next. The first case of a pandemic in COVID-19 in Mali occurred in March, the last week of March, and we can see on the figure at the left, the infection has spread in our country, and all the regions are concerned by this infection. From the beginning and to today, we have almost 3,000 cases of pandemic COVID-19 in Mali. Almost 200 patients have recovered, and more than 400 are now under treatment and follow-up. Slates. What is the impact of COVID-19 on maternal and neonatal care in Mali? Slate. If you see those figures, we can note with the first presentation, we can see COVID-19 has had an impact on the indicators of health in our country. If we look at the first figure at the left up, we can see the impact of COVID-19 on the rates of preeclampsia and eclampsia, and we can see also the high level, the increasing rate of lethality during COVID-19 period. It is the case for the cases of hemorrhage and obstetric complication. States. If you look at this table, what we can retain: consultation number, delivery, cesarean, cervical cancer screening, prenatal follow-up, and hospitalization day, and planned surgery have reduced to almost the half of the case. However, the stillbirth rate has raised, and we can see the rate of raising almost 447% of cases of stillbirth have been noted. Please. What is the impact of COVID-19 on maternal and neonatal care in Mali? In Department of Pediatrics, COVID-19 has negative impact on the number of neonatal visits in this department, and the immunization of babies, and the high rate of neonatal death because of reduction of number of pediatricians and other health workers in our country. Next. So our professional societies, Malian Societies of GU, Association Malian Society of Pediatrician and Midwife Societies faces too many challenges. We have to contribute and to understand the risk of COVID-19 in health area. And secondly, the duality of opinion for continuation for essential care for mother and children, and to be exposed, the risk to be exposed to infection. In this context, we have to provide newborn and maternal care, promoting of breastfeeding of baby born from COVID-19 positive mother, providing kangaroo mother care, maintaining antenatal follow-up, especially for women with a little bit risk pregnancy. And we can see also the program of uterus cancer screening program and PMTCT program to be assisted by patient. Next. How also ours were responding of our societies? Slides. Okay, first we have developed in collaboration with Malian Society of Pediatrics and Midwife Society guideline in context of COVID-19. First, we did a workshop slide, and we have developed this guideline in French, prevent charge the COVID-19 during pregnancy, delivery, and neonatal period. Slide. And this guideline, we can see COVID-19 management algorithm for women who came in our services in context of COVID-19 when they are pregnant, during for delivery, slates, and after delivery in the postpartum period. And one interesting thing was for us to develop an algorithm for the women after delivery, after management of the pregnancy and the COVID, the return into the community. It was very important because in our society we had many problems around this context, in this context of COVID-19 for patients after covering their health. Please. And so our societies have many things to do, plays an important role in prevention and control measure by sensitization of our members first and sensitization of the people. The second role we played was to training and capacity building of our members, GO, pediatrician, and midwife. And the last was the experience sharing of good practice with some societies out of our country, especially from Burkina Faso and Cameroon. We also have a strong partnership with NGO. We can cite here USAID group in Mali, government and other health professionals to reinforce capacity building of health workers. Please. So before we finish, we have also implement our guidelines and to do the dissemination of this guideline in other social health or reproductive in facilities. We have also contributed to the promotion of telemedicine consultation with the public health department of the Faculty of Medicine to provide maternal, newborn, and child health services in case of less risk factors in pregnant patients. And we have also done training of health workers in this context via webinar and Zoom system to improve the availability and quality of care. And we have contributed with the Ministry of Health to reorganize our service to provide emergency and maternal and neonatal care. Slides. Before I finish, before conclusion, I want to renew my thanks to all of you who has organized this session and all the members of USAID group in Mali, all the members of our society of GO, Malian Pediatrician and Midwife Society. What we can say, COVID-19 pandemic has a negative impact on maternal and neonatal care availability. Low using of service because of fear of patients and health workers, reduction of number of health workers to avoid contamination of them. And professional association has our societies gave their genius to provide the best care during this period. I think it is the last slide. I want to say slides. Thank you so much for your attention.
Thank you very much, Professor Traore. Next,
Thank you.
it is my pleasure. Thank you. Next, it's my pleasure to introduce Sarah Nyirongoma, who is president of the Midwives Association of Zambia. She's been a registered nurse midwife in Zambia for over 26 years and a strong advocate for women and human rights-based approaches in her practice, as well as quality and equity, and working as the capacity development specialist at PACT Zambia. Over to you, Ms. Ngoma.
Thank you very much, and good morning, good afternoon, everyone. It's my pleasure to present to you the Zambian experience for the COVID-19 disruption of maternal and neonatal care. So, next slide, please. So, I'll first start with the response as a Midwives Association. Firstly, our role is really to look at the professional conduct of the midwives and also to ensure that quality of service is provided to both women and the newborn. So our association is comprising of midwives across the country and also non-midwives who are as associate members. So the Midwives Association of Zambia collaborates very closely with the Ministry of Health, and from the time that the pandemic came through, we've been working very much close with the Ministry of Health. Next slide, please. So the first positive cases, just like any other country has reported, was in March, and mostly came through the truck drivers who are coming through the borders. And Lusaka, which is the capital city, was the epicenter as of March. So that's where most cases were found, although the first two cases were found somewhere in another province. But as time went on, most cases were found in Lusaka, as it is a transit area for truck drivers going to the other part of Zambia. So Ministry of Health, Public Health Institute also just formed up a team very quickly and started mobilizing the test kits. Next slide, please. So as frontline workers, what we did first was to have trainings being done under Ministry of Health. So the nurses and midwives, doctors, laboratory technologists were all trained on how to handle a COVID client. As that was being done, we were also oriented on how how many epicenters we're going to be set up, and also the campaign on staying at home started as the president of the Republic of Zambia pronounced it during that month. Next slide, please. So the effect that was there with maternal health was that we saw a reduction in the number of women attending antenatal, and this probably was due to the stay-at-home, campaign. And we also saw an increase in home deliveries, and the under 5 clinics were suspended. We also had, family planning uptake suspended in most of the government facilities. Next slide, please. So the association got, they got concerned over the issue of having, a number of women delivering at home, and we had to write to the permanent secretary for support, because initially those who were being supported mostly were, outpatient departments. The maternal and child health was not was seen as not really affected. But when we saw the reduction in the antenatal care, we had to write to the permanent secretary, and we saw a multi-stakeholder meeting being called where the association was involved in developing the guidelines. The first guidelines were developed in May, and those were general guidelines. So maternal child health was just a portion, and it wasn't detailed. So a request followed up with UNFPA to support, and also the World Health Organization. Meanwhile, the International Confederation of Midwives was also on board, and we were collaborating and also attending the virtual meetings. So we had that, stakeholder meeting, and the guidelines were developed. So all the activities that we were supposed to have this year, being the year of the nurse and the midwife, were postponed. We had quite a number of activities laid down, and even the International Day of the Midwife was postponed, and most of the trainings, mentorship trainings, were all postponed. Next slide, please. So capacity building for the frontline providers. The guidelines on management of pregnant women and antenatal women, labor and birth, postnatal, were adopted, the ones that we participated in developing. And then the World Health Organization responses and guidelines updates in line through through intrapartum ECHO Zoom meetings. So we had quite a number of ECHO meetings, Zoom meetings with the midwives, which the presentations we're using were those ones we're getting from UNFPA and from the World Health Organization, just to make sure that the midwives were up to date with whatever was going on. Because most of the times we find that the midwives are left out with pandemics. So we had shared the webinar presentations on IPC, PPEs, and respect for maternity care. We looked at respect for maternity care because we saw that midwives were going to be shunning away from women, whichever women came to the facility, and so we wanted to make sure that everyone was ready and provided the respect that every woman, has the right to the services. So we had to have such kinds of webinar presentations just to prepare the midwives psychologically. We also saw that, the PPEs were not enough. So we looked at how can we have, a few PPEs, sourced from partners here and there. So we were working with the UNFPA, who had promised to provide that for us. Next slide, please. So the PPE for midwives were not really enough, but we did the donning and doffing training just to also ensure that those who had the PPEs could be able to have something that they could be, they know how to use the PPEs. Next slide, please. The challenges, as I said, is inadequate PPEs and inadequate protection for women and their babies. Of course, we haven't had a lot of information on how many women had come with COVID-19 in maternity services, except maybe for just a few cases that we've seen. And then there's been inadequate IEC materials to communicate with women, so that this time after we didn't have any lockdown, by the way, but we had some of the services, disrupted or stopped. But after the disruptions everything that was stopped was lifted up, we had now to start, communicating with women so that they can continue coming to the facilities to come and access the services. Next slide. So the recommendations were the use of application, maybe so that we can have, women communicated to through the phone messages so that they can start coming to the facilities, and also use of mass media communication to allow women, to ask women to be coming for the services. Next slide. Thank you so much. Ready for questions.
Thank you so much, Ms. Ngoma. Really such rich experiences from each country, and I really am grateful for the sharing of those. We just have a few minutes left, so what I'm going to do is to ask 3 questions that each of you can make a brief comment on, a 1-minute comment, if you will, please, before we close. So the first question relates to data. One of the challenges of this pandemic, as we have seen, is getting access to the numbers and understanding what's actually happening on the ground. And I know one of the challenges that we have faced at the AAP is being able to adapt guidelines in response to data. So we have actually changed our guidelines around keeping mothers and newborns together now that data has been published that shows that it does not increase transmission from mother to child. I believe there is a link to our guidelines provided in the chat box, which all of you may refer to. But I would ask you, is there any process that you have put in place in your countries for changing or adapting your guidelines as new data becomes available? The second question is related to how you may have modified the essential newborn care protocols in your hospital during this time of COVID. And there was a particular question about breastfeeding and what you are allowing or encouraging about breastfeeding in your countries. And then finally, I think this is a time of challenge and even despair for so many of us as we see our coworkers and our families fall ill, as we see our government struggle to respond to these crises. So please share with us whatever you have that may give you hope about what will come next. So those are the 3 questions: about data, about modifications of protocol and breastfeeding, and what is your best hope. So I'm going to go in the order of the speakers. So if please, Professor Shahidullah, if you could respond first with 1 minute. You're on mute, sir. There we go. I think I heard you.
Okay. Can you hear me now?
Yeah.
Yes.
Yeah. In Bangladesh also, we had some hiccup at the beginning regarding the collection of the data, entry of the data in the district health information system too. And that is because that in the month of April and June, April and May, I mean, there was a fear and everything was kind of a halt, and there was also a lot of problem in entering the data and collecting the data. But now it's being it has been picked up, and more or less it has come back near normal. Regarding the essential newborn care, and particularly the breastfeeding, we had a lot of discussion because there was some difference between American Academy of Pediatrics guideline and the WHO and UNICEF. So finally, we stick to the the WHO and UNICEF, that we are encouraging breastfeeding for the newborn even after birth of a COVID mother within an hour. So it's there. I mean, we didn't have to make any change except that the mother has to take precaution. That part has been included. Regarding the health worker and getting sick, it is a great concern and it's still going on. And we have more than 1,000 doctors, particularly, and many more nurses are being affected, and more than 100 doctors have died during the COVID period. So, but finally, things are again falling in place. Things are improving in terms of maternal, newborn, and child care.
Thank you so much. Dr. Karanja Chege.
Yes, thank you. With regards to data collection in Kenya, that has been going on quite well. In fact, the data is available for viewing at the Ministry of Health website. They actually have daily data from the situation reports, and then weekly they have the epidemiological kind of consolidation. So that data is there. The only challenge is we do not have very specific data for pediatrics. It's all quite generalized and lumped up into groups of 0 to 9 years, 10 to 19 years. With regards to breastfeeding, I actually did an interview today for one of our national media stations, which is going to be aired later tonight on Prime News, that we are encouraging mothers to continue breastfeeding because breastfeeding remains the safest source of nutrition for the baby below 6 months. So we're encouraging breastfeeding with precautions of hand hygiene and masking anytime you're handling the baby as much as possible. Now, with regards to our healthcare workers, burnout and death, we've had one death of one of our dear gynecologists, which was very sad. It happened last month and really shook the medical profession. We've had several other doctors and nurses falling sick, but all of them have recovered. We have very good support systems in place. We have a number that any healthcare worker can call if they're even in psychosocial distress. We have webinars that happen just to address healthcare well-being and issues and to brainstorm on things, and that has been very, very helpful. So that is all I have to say. Thank you.
And what gives you the most hope?
Oh, what gives me the most hope? What gives me the most hope is that in a way we have seen our healthcare systems improving because things are being put in place to take care of respiratory patients. Our ICUs are coming up. So I feel like we are well placed even to handle another pandemic. We are getting there. So that gives me a lot of hope.
Excellent. And that is indeed, I think, the hope and aspiration for so many of us in so many countries is really trying to use this crisis as a way to build systems. Professor Pulugan, that you are up next. If you could comment again. Mm-hmm.
Okay. In terms of data, having said that, at the beginning it's quite difficult to get the data from the government, and even until right now, we have the data only numbers. So that's why we have about 4 guidelines. We cannot have any guidelines without knowing what's the cause of death. So, and then that's why start from 17th of March, every single week, we have a meeting every Monday with all the PIC from the province and also chapter of the Indonesian Pediatric Society. Then we know that it is quite difficult because maybe the children, the cases and also the mortality is higher in the government data. But our data is genuine data. This is what the pediatrician taking care. So let's say, I can say CNS infection, cause of death, 7 cases, tuberculosis, malignancy, malnutrition, GI, dengue, cerebral palsy, prematurity, congenital heart disease. This is all the mortality. So we have to make ourselves to have this data, and we will publish it later. This is about data because we cannot wait. They don't know. Nobody knows about pediatric data. The only thing they know when there is data and come late, and then after that they make a swab of postmortem. PCR, and after that, okay, that's it. No action after that. So we think we have to have our own data. So this is what we can say, and also related to right now, every single cases, any death from pediatrician, we have to talk. We have our special task force, and then we see. And right now, maybe every week right now, maybe like last week, only 1 or 2 cases died. This is about the data. About the breastfeeding guidelines, we have our own guidelines. Well, of course, some from WHO and also we learn from the AAP and also some other society. But we make modified with the local situation in Indonesia. And we know, we are sure, if the guidelines do or we doing it at the hospital or center, health center, primary health center, it's okay. The problem is when they go home, the community, they don't support. They cannot prevent the mother and the baby from the infection. The father has to work, and a lot of community, they don't wear masks, not enough, hygiene system. So a lot of complicated things. So we have a good guideline, but implementation, the guidelines in the community is much more difficult compared to make implementation in the health center or in the hospital. In big hospital, there is no problem. Everything we can conduct it. Even the primary health care, the guideline of breastfeeding, we have it. Even maybe.
Yes, excellent.
Yeah. And next one about the facility in the healthcare, we have more than 70 deaths of the doctor right now. So we feel really sad. And some of them not from the hospital, but from the private practice. Because maybe in the, let's say like even the pediatrician, maybe in the other island, most of the people, they still do private practice. So there is no screening, there is not enough PPE sometimes, but they cannot close the practice. They cannot close the clinic, right?
Yeah.
Yeah.
Okay, thank you so much for sharing that, Dr. Pulungan. I need to move on now to Professor Yusuf Traore. Could you comment quickly, please?
Okay, thank you. What I can say is in Mali, in the ground, the challenge is how to reduce the fear of health workers and patients to do their return to health center to health center area, and people to accept testing in our country. If you look at the house slates, we are between all the presentation, the country which has the number of COVID-19, the less number of COVID-19 infection, and I think it is related to the number of testing we do a day. In Mali, we have less than 200 testing a day. And the second thing I can say is to our society are facing to reorganize the management of other complications without COVID-19, because we have noted in our context other complications are responsible to high rate of maternal and neonatal mortality without COVID. And our most hope is the commitment of health workers who work in the domain of sexual and reproductive health to reduce the spreading of COVID-19 and to face to other maternal and neonatal complications, and despite our low resources. So
thank you.
That is my response. Yeah.
Excellent. Thank you so much. I do believe that our healthcare workers are perhaps our best hope. Ms. Ngoma, would you make your final comments, please?
Thank you so much. Yeah, so in terms of data in Zambia, we also just have, lumped up data. We do not have any information of segregated data. We've only had one baby who was infected recorded, and that was a 3-month-old baby who survived. So the data is just lumped. In terms of breastfeeding, so immediately we started having, the COVID information, we received quite a number of information from AAP through Cassie. So she sent us a lot of presentations which we started using through our webinars. And then we also adopted the World Health Organization a guideline. So breastfeeding is being encouraged for all the neonates. In terms of health workers infected, initially we had quite a number of those infected, but they all got healed. Nobody died. We only had a death last week of a senior midwife who died of COVID, and that's very unfortunate. Otherwise, most of those who got infected had healed. The only problem that we had was in a quarantine of 14 days, so that created a lot of shortage of staff, where those who were exposed were quarantined, but we are moving with it. So what is keeping me going, or keeping us going? We've had some webinar again, shared through AAP, where we discussed the psychological effect, mental effect of COVID on health workers. So with midwives, we have that presentation that was done, and a lot of questions were asked, and I think we are moving forward very well. This is the time that Zambia has reached its peak. So with 241 total deaths recorded since the pandemic started, and with the new infections, which are on average 200 per day, we are now very cautious and still talking to one another, and this is the time that we are on our feet and ensuring that we support one another. Thank you.
Thank you so much. Thanks to all of our panelists for the wonderful experiences that you have shared, wonderful learnings, I will say, perhaps not wonderful experiences. And a special thank you to Save the Children, one of our partners in maternal and newborn health work, who co-sponsored this webinar. I wanted to highlight the next one coming up on August 25th. It will be focused on early child development in the time of COVID. I hope you will join us for that webinar as well. Thank you so much for joining, everyone. Have a great evening and day. Okay.
Good night.
Thank you.
Good night.
Thank you.
Good night from Jakarta.
Thank you, and good morning and good night to Western East.
Okay.
Okay,
Hi,
thank you.
Saidullah.
Thank you very much. Bye.
Come on.
Hey, Saidullah.
Good to see you.
Yeah. Assalamualaikum.
Waalaikumsalam.
Wah. Okay. Good night.
Okay. Ciao, ciao.
Okay. Okay. Ciao,
Thank
ciao.
you so much, everyone.